Hello everyone, I am Dr. Muhammad Samah, General Physician in DPRC. Today I will speak about autonomic dysreflexia. Mr. Ahmad is a 27 years old man whose spinal cord was injured in a motor vehicle crash, which resulted in a complete quadriplegia from the level of the fifth cervical neurologic level, with no movement or feeling below the level of the biceps muscle. He is otherwise fairly healthy. He uses an end-dwelling catheter for bladder management and evacuates his bowels twice weekly. During evening round, he complained about severe headache, sweating, and nasal congestion. Vital signs reports to the physician on duty that his blood pressure is 135/95, and he is feeling worse. So, by definition, autonomic dysreflexia is a potentially dangerous and, in rare cases, lethal clinical syndrome that develops in individuals with spinal cord injury at or above the sixth thoracic vertebral level. It is considered as a medical emergency and must be treated and recognized immediately. The presenting symptoms of autonomic dysreflexia include a bilateral pounding severe headache, along with sweating above the level of the injury. Signs include flushed, sweaty skin above the level of the lesion and cool, pale skin below this level. The main physical finding is elevation of the blood pressure. It is important to remember that resting blood pressure declines after a spinal cord injury, often to the range of 90/60. This means that even readings of 120/80 might be considered elevated. Any painful, irritating, or even strong stimulus below the level of the injury can cause an episode of autonomic dysreflexia. The two most common causes are bladder distension and/or fecal impaction. Other causes include urinary tract infection, epididymitis, bowel distension, reflux or gastritis, hemorrhoids, appendicitis, or any other intra-abdominal pathology or trauma, anal fissures, deep vein thrombosis, pulmonary emboli, pressure ulcers, ingrown toenail, burns on sunburn, blisters, insect bites, contact with hard or sharp objects, temperature fluctuation, any constrictive clothing, shoes, or appliances. Complications and morbidity associated with autonomic dysreflexia result directly from severe peripheral hypertension and include retinal cerebral hemorrhage, myocardial infarction, and seizures. Autonomic dysreflexia can be prevented through the regulation of the bladder routine via indwelling catheter or intermittent catheterization, preventing UTI, a regular bowel program for the prevention of constipation, infection, and ileus, routine weight shifts and skin checks to prevent ulceration, and pain management. How to manage autonomic dysreflexia? Sit the patient up, keep him in sitting or upright position until BP returns to normal. Loosen or remove any tight clothing. Monitor blood pressure every 2 to 5 minutes. For patients with catheter, check tubing if not blocked or kinked. If catheter blocked, remove and reinsert using lubricant containing lidocaine. For patients without catheter, if bladder is distended and patient is unable to pass urine, insert one. If bladder distension is excluded, gently examine the rectum. For fecal mass in the rectum, gently insert gloved finger covered in lidocaine gel into rectum and remove fecal mass. If systolic blood pressure is above 150 mg mercury, start immediate pharmacological management. The first line is 10 mg oral nifedipine.